Okay. Good morning, good afternoon, wherever part of Africa, West Africa that you are listening to us. I'll be presenting the penultimate lecture in the third Telecleft series. And this lecture is titled Orofacial Cleft, a Missionary Hospital Experience. It's so great having you, Professor Akadiri, as the moderator of this session. My outline is as follows. Introduction, I will talk about what is presently known about orofacial cleft. Thereafter, describe the Sacred Heart Hospital experience. Orofacial clefts, including cleft lip with or without palate, and cleft palate without cleft lip, is amongst the most common birth defects of the head and neck region. These deformities usually are cosmetically conspicuous and therefore constituting a serious affliction to both the patients and their families. There is a wide variability in the incidence of orofacial cleft worldwide, and there is wide geographic and ethnic variation. The incidence has been found to range from 1 in 600 to 1 in 1,000 live births, sometimes as low as as high as 1 in 2,000 live births. The highest incidence has been found to occur among the Asians, while the lowest incidence is said to occur amongst Africans, with an incidence of 0.5 in 1,000 live births. A slight male preponderance of orofacial clefts have also been reported, with cleft lip having a male to female ratio of 2:1, while isolated cleft of the palate is said to occur more commonly in females with a male to female ratio of 1:2. Generally, unilateral cleft lip is found to occur common on the left, and it is also found 9 times more commonly than the bilateral cleft lip. The etiology of cleft lip and palate is complex and generally unknown. It's been said to be of multifactorial etiology involving an interplay between genetic and environmental factors. The genetic and environmental factors actually have been described in the preceding Telecleft series. I will just mention some of the environmental factors. Environmental factors such as maternal smoking and drinking of alcohol during pregnancy, usage of anticonvulsants, retinoic acid, and folate deficiency have been found to have been said to contribute to orofacial clefting. Other factors such as gestational diabetes, maternal obesity, stress, ionizing radiation, all have been linked with increased risk of orofacial cleft. A study conducted in the South-South geopolitical zone of Nigeria has also found out that the use of firewood in cooking has been said to contribute to clefting in that part of Nigeria. More than 70% of orofacial clefts are non-syndromic, while approximately 30% are syndromic. Several associated syndromes have been found to occur among patients with isolated cleft palates, and this is seen in approximately 50% of cases when compared to less than 15% of combined cleft lip and palate patients. The definitive management of orofacial cleft usually involves a multidisciplinary team approach, and comprehensive cleft care is usually done from childhood into adulthood. Reconstructive surgeons such as maxillofacial surgeons, plastic surgeons, pediatric surgeons, otorhinolaryngologists are part of those involved in the reconstruction of orofacial clefts. Others that are involved in the multidisciplinary team of orofacial clefts include pediatricians, pedodontists, orthodontists, prosthodontist, speech and language pathologist, audiologist, geneticist, psychologist, nurse practitioner, and the social workers. The Sacred Heart Hospital is a Catholic missionary hospital that was established in 1895. This year, the hospital became 125 years old. It's the oldest hospital in Nigeria, and it provides an array of qualitative health service that enhances the dignity of the human person. Her services cut across surgery, medicine, obs and gynecology, pediatrics, accidents and emergency. The center is accredited for training of medical personnel in the fields of family medicine and nursing science. It is located in the heart of Abeokuta, South Local Government Area of Abeokuta, the capital of Ogun State, in the southwest region of Nigeria. And the hospital is located also in the Ogun Central Senatorial District in Ogun State. It operates at the secondary level of care, though with some tertiary attention. This slide shows the picture of the front of the hospital. The Smile Train Sacred Heart Partnership officially started in July 2010. Prior to this, the then Smile Train coordinator for West Africa, Mr. Remi Adesheun, desired to have a center established in Ogun State. And this was after several centers had sprung up in the adjoining states, Lagos State and in Oyo State. So they wanted a center in Ogun State so that patients with orofacial cleft deformities will not have to travel far to access treatment. So they made a move and contacted Sacred Heart Hospital. And after this, after a series of meetings, the partnership thereafter became official. Before the clinic started running, the hospital created an awareness within the state on orofacial cleft deformity, and also to let people be aware that they can now access treatment at no cost to them, but of course at a cost to Smile Train. Our clinic runs weekly. Our team is composed of an oral and maxillofacial surgeon, a pediatrician, nurses, the anesthetist, and administrative and social welfare officers. Typically, when the patients come in, this case reporting form is used to take detailed history and clinical examination. And this case reporting form is actually fashioned after that of the one used in Obafemi Awolowo University Teaching Hospital, where I had my residency training program. So the data of the patient is taken, the family history. We also try to elicit if there's any familiar member with history of orofacial cleft. Then detailed antenatal and perinatal history of the patient is also taken. Detailed maternal pregnancy history is taken. The immunization history is very critical to us because in some instances, you see the patients or caregivers presenting to the clinic without having enrolled the child for the routine immunization. So when they come like that and we discover it during the history taking, we usually commence the immunization for them at our center, and thereafter we tell them to go to the nearest primary healthcare center to them to continue with the immunization. Detailed systemic review of the patient is also taken, and a clinical examination done to arrive at a definitive diagnosis. The cardiovascular system is also very particular. We also take the history. Then a summary of the problems that the patient has is taken, and we thereafter formulate a treatment plan. Part of the things that we do during the first visit is to give psychological and dietary counseling to the parents or caregivers when they come in during the first clinic appointment. We also ensure that the pediatrician also review these patients so that those that need other um, tests or further investigations to be done, such as echocardiography. These are picked by the pediatrician, and they go for such other investigations. The treatment plan is outlined, and patient is followed up still with this case reporting form, which we keep, which our administrative officers keep with them. But when the patient is now fully ready for surgery, we now enroll them in the general medical record of the hospital. While the patients are waiting, this is a slide showing the norm now because of the current COVID-19 pandemic. You can see the parents and caregivers with their face masks and also trying to follow the social distancing protocol as part of the non-pharmacological management of coronavirus pandemic that is currently ongoing. So when the patients come like that, we usually like them coming about maybe 30 to 45 minutes before the actual clinic starts running. And this is to allow those new patients, when they come, to interact with them. Because usually when the new patients come, you see them with varying degree of anxiety. But by the time they interact with the patients that have come for post-op review, their fears, some of the fears that they come with, usually are allayed, such that by the time they now come in to see us, they are assured that there is a solution to the problem that they have brought to the center. Since inception, a total of 278 patients have been seen, with the ages ranging from 5 days old to 65 years. A slight female preponderance have been seen in the clinic, with a male to female ratio of 1 to 1.6, 1 to 1.6. In all the various types of clefting that we saw, there was a slight female preponderance in all the categories. For the cleft lip and palate, it occurred more commonly in females with a ratio of 1 to 1 to 2. Isolated cleft palate also occurred more in females with a ratio of 1 to 3. Tertiary 7 clefts, which has been said to be the most common facial cleft, was also occurred 3 times more in females as compared to males. The unilateral cleft lip was also occurred more on the left, but at a slightly higher ratio than that of the right, ratio 1.2 to 1. And it was also found to occur 4 times more than the bilateral cases of the cleft lip that we have seen so far. And we know that congenital anomalies is also has been said to occur, especially with isolated cleft palate. In our series, about 7.2% had associated congenital anomalies. Out of these, musculoskeletal anomalies accounted for the most cases of congenital anomalies that we saw, and that included syndactyly, polydactyly. We also saw cases of cardiac anomalies, dextrocardia, atrial septal defect. For the patient that had dextrocardia, the pediatric cardiologist also advised that an ultrasonography must be done before the patient can have surgery. And this is to also find out if there's dextral rotation of the abdominal organs. This we did, and there was no dextral rotation of the abdominal organ. Congenitally missing globes were also seen in a series. The slide here shows on the left, congenitally missing left globe, while that on the right shows congenitally missing right globe. For those with congenitally missing globes, we usually refer them to the visiting ophthalmologist in the center for detailed ophthalmological examination and counseling to the parent and the caregiver. So things like Talipes, equinovarus, and skin warts were also part of the congenital anomalies that we saw in a series. This slide shows table 1, and it shows pattern of age at presentation as compared with period of clinic commencement. When the clinic first started, in the first 3 years, about 50% of the patients that presented actually late to access treatment. But over time, a progressive decline was seen in cases of late presentation for treatment, such that in the last 1 year, over 80% of our patients presented under the age of 1 year to access treatment. This is the pattern of the adult cases that we were seeing in the first year of when the partnership started. The patient on the left is 45 years old, while that on the right is 39 years old. Then these are also young adults. The patient on the right presented to the clinic at age 34 years. Interestingly, the one on the right was a 27-year-old male that was actually preparing to go for the mandatory 1-year National Youth Service course scheme. So when he now learned about when he now got to know about the free treatment that could be done for his deformity, he presented and he had the treatment done before proceeding for the mandatory NYC program. In a paper that we published during the first 18 months of our existence, we were able to see the paper actually observed that 70% of the patients in our series presented late for treatment in the first year. And the reasons that we found was similar to reasons that have been reported from other studies in Nigeria and also in Africa. And the reasons, some of those reasons for late presentation include financial constraints, ignorance, long distance from cleft center, cultural beliefs, fear of surgery. In our series, we actually saw a family that the man came with a 2-month-old baby that had cleft lip deformity. In the course of interacting with him, he now informed us that he also has an older child that was about 6 years old that also had isolated cleft palate. But that one is not going to bring the child for repair because he knows that we're going to do the repair gain access for the repair through the brain. Of course, his fears were allayed. So after his baby with the cleft lip deformity was repaired, he was now confident to bring the older one that had isolated cleft palate for repair, and this was also done. So we can see what fear of surgery can do as one of the reasons why people present late for treatment. In the course of the running of our clinic, we found out that about 50% of the cases that we see were actually from the Ogun Central Senatorial District, and this is where the hospital is located. And we've also seen over time that many of the patients that present for post-op review visits, majority of them also are also from this senatorial districts. Of course, this is not far-fetched. This is because of the proximity to the treatment center. Just about over 10% of our patients came from outside the state, the adjoining states, that is Ogun State, that is Lagos State and Oyo State. And usually we don't even really encourage patients coming very far to access treatment because we have several centers in Lagos State and Oyo State, because majority of the patients that come are in the low socioeconomic strata, and we usually don't want to further burden them. So very few were seen from these surrounding states. Our surgeries usually are carried out following the smile train protocols. For the cleft lip repair, a slight modification of the rule of 10 is followed. The surgery typically is done when the baby is at least 12 weeks old, not a day younger than 12 weeks old. The weight also at least 4.5 kg, and hemoglobin level at least 9.5 kg, 9.5 gram per deciliter, in the absence of any underlying medical condition. For the cleft palate, though it's been said that repair can be done from 6 to 12 months, as from 6 to 12 months, typically in a center, the repair is done at least when the child is 12 months old, with the weight at least 9 kg, and also in the absence of any underlying medical ailment. We've had to optimize those that are not, fit. For those that are malnourished, we've had to over time, encourage them such that by the time they now come, the weight is optimal for surgery. Some that are anemic and we've tried to, monitor without transfusion, we've had to sometimes bring them in, transfuse pre-operatively, optimize them before surgery takes place. So a total of 284 surgical interventions have been carried out in 235 patients that we have seen over the 10-year period since the program started. The 50% of the cases that we've operated on are isolated cleft lip, while nasal cleft and submucous cleft accounted for the least number of cases that we have operated on. I'm now going to share some pre and post-operative images of the patients that we have seen in the course of this program. This is a picture of a 4-year-old girl. This is the pre-op unilateral cleft lip. This is 10-day post-op picture of the child after the repair was done. This is that of a child with bilateral cleft lip. This is the post-operative day 7 picture, 9 months post-op picture. This is a picture of a secondary cleft of the secondary palate, pre-op picture, 10-day post-operative picture, tertiary 7 cleft. This is the pre-op picture, intraoperative view, and 7-day post-operative picture. This picture, I purposely brought it to showcase skin reaction to topical antibiotic ointment. When the patient came for this post-operative day 7 review, we observed that she was reacting to the topical antibiotic ointment, which we usually place following cleft lip repair. So when she came in for the review, we asked her to discontinue with the genticin ointment. So by the time she reported for the 14-day post-op picture, the skin reaction had stopped, and at 28-day period, it had totally disappeared. Alongside the clinical cases that we carry out, we have also published some of our findings in journals to contribute to the existing body of knowledge of orofacial cleft. The last picture that I showed of the patient with the skin reaction to topical genticin ointment actually led to this paper that was written. Before this paper was written, we had presented that patient as a case report at a scientific conference. Thereafter, we now went ahead to do a randomized controlled trial comparing the outcome of wound and cosmetic appearance of to compare the outcome of wound and cosmetic appearance in a randomized control trial of following cleft lip repair, whether there's any difference when the wound is dressed or when the wound is not dressed. And we arrived at the conclusion that the surgical outcome and patient satisfaction was not in any way affected whether the wound is dressed or not. We also published our experience when we first started, and this was where we found out that About 70% of patients that we saw when the clinic started in the first year presented late to access treatment. Then in the series that we also saw there, we recorded no consanguineous marriage, because this has been said, this has also been said to contribute to clefting. But none of the series that we saw in this experience that we documented then had history of consanguineous marriage. And this is not far-fetched, because in the southwest region where our center is located, consanguineous marriages is not routinely practiced. So this might have been the reason why we didn't see any of such in this paper that was written. Anesthetic management of during surgery for cleft repair can be very challenging, and this is because of the abnormal airway anatomy. So because of this, we sought to determine the characteristics, type, and incidence of associated medical problems, airway, and other intraoperative complications in patients that presented to our facility for cleft lip and palate repair. And we found out that anemia and upper respiratory tract infection were the predominant comorbidity that were seen in patients that presented for surgery. So because of the risk of a wide range of perioperative airway complications, it necessitates the presence of skilled manpower during general anesthesia for cleft lip and palate surgery. Over time in developing countries, we've seen that most times caregivers usually fail to attend scheduled clinic appointments. So this paper decided to highlight some factors that are responsible for non-appearance at scheduled clinic appointments. And we were able to conclude that illness, pressure of work, and also financial constraints were the major factors that we saw that accounted for non-attendance at early review appointments after cleft lip and palate repair. And this we know can greatly hinder comprehensive care that can be given to patients with cleft lip and palate deformity, because a patient that has cleft palate that is supposed to come for treatment at maybe between age 12 months to 18 months before speech forms, and the caregiver absconds for clinic only to represent when the child is about 10 years or when the child is much older. We know that the quality of the speech following that repair may not be as very optimal as if the patient did not miss clinic and presented early for the repair. The next couple of series as I round up is going to show what we are and what we do. This is a slide showing some of our team members in the theater. This is a slide of us during an operative session. This is where we offer postoperative care. Prior to 2017, when we finish our cleft repair, once the patient has recovered at the recovery ward, at the recovery area, thereafter they are sent to the ward for further monitoring. But due to a sentinel event that we had in 2017, following that sentinel event, we thereafter ensure that all cases of cleft lip repair stay at the area that we designate as the post-anesthesia care unit, where they are monitored for 24 hours before, and they are fully recovered before we now thereafter transfer to the ward for onward monitoring. For cases of cleft palate repair, we ensure they stay at this unit for 48 hours for close monitoring before we now transfer them to the ward for onward monitoring and care. And usually once the patient is conscious, recovered, we usually bring in their mothers to sit by them, so that by the time the patient is hearing the mother talking, cooing to them, they are comforted and they are less agitated. So we bring in the mothers early to sit with them following repair. Over time, we've participated in several awareness creation in order to keep the center running. We've also participated in Smile Train Cleft Awareness Week about twice, which was fully funded by Smile Train. Sensitization has been done on orofacial cleft deformities in the radio. We made radio jingles. We've gone on air to sensitize people about the deformities and also to let them know that the care is available at no cost to them. And this has also improved our clinic attendance. We've also created awareness in the marketplaces. Being a missionary hospital, when sometimes the hospital also goes for his religious outreach programs in the neighboring villages, we also carry out awareness. We also create awareness about orofacial cleft deformity, so that when they see cases like this, they should encourage them to come to the hospital to access free care. In our country, and I'm sure in other African countries, about 70% of our pregnant women still access care with traditional birth attendants. And because of this huge number of pregnant women that go to the access care at the traditional birth attendant places, the center has organized a program wherein representatives of all traditional birth attendants within the state were brought to the center. We had the pediatrician to teach them, to train them on neonatal resuscitation. The obstetrician also was there to teach them the common signs and symptoms that they will see that should prompt them to refer the pregnant women promptly to the hospital for further treatment. At that place too, during that program, we also enlightened them about orofacial cleft deformities. Many of them were actually happy because some told us that they've been seeing such patients and didn't know how to help them. So this we have done, enlighten them. This is one of the flyers that we use for our enlightenment program. This flyer, all the patients in this program, we actually took their consent before putting their pictures on this flyer. Those that did not consent were not put on the flyer. So this is part of our team in the market sensitizing. This is us at the Mato Park during a sensitization program. As I bring this lecture to a close, I would like to say a very big thank you to Smile Train, especially our coordinators, Mrs. Nkiruka Obi, and also our ever smiling Mrs. Victoria Awazi. They've been very encouraging, and at every point they've been there for us. The picture that is shown here was actually taken at the recent stakeholders conference that took place, the Southwest edition that took place in Lagos. So with our partnership with Smile Train, we've been able to change the world one smile at a time. This presentation will also not be complete without me acknowledging some of my mentors and teachers, Professor Fadekemi Ogini and Professor Fatusi. They were very supportive when I was about taking the mantle of the partnership. They were very encouraging because I was a very young surgeon when I started it, but they encouraged me and they've also been there for me. I also want to thank Dr. Bola of UCH Hospital, Dr. Olusonya, Dr. James. These people have been very supportive to me in my journey. And I also want to thank all the participants at this meeting, and I wish us a prosperous pandemic-free 2021. Thank you. Merci beaucoup. Obrigado.
Wonderful, wonderful presentation, Dr. Ogunmuyiwa. Can you hear me?
Yes, I can hear you.
Can you hear me, Dr. Ogunmuyiwa?
I
I'm
can hear
sure
you.
there's... Yes, I'm going on. I'm sure there's a lot of applause going on virtually. You may not hear it. It's a virtual clap, virtual applause.
Thank you
Distinguished
very
ladies
much.
and gentlemen, it's been a great time. So we have a few questions for Dr. Ogunmuyiwa, and then we'll take this now. Okay, the first question, Dr. Ogunmuyiwa, somebody wants to know whether you have a preferred method of repair in your center, and whether patient wants to know that the patient pay. I want to assume this on that smile train, but you can answer the question in terms of any cost to the patient at all, in the course of management. And then what is the turnaround time between time of presentation and time of surgery?
Okay, turnaround. Thank you very much for that, for those questions. For the repair type that we do for the unilateral cleft repair is the Milan rotational advancement that we do, or its modification. For the bilateral cleft, the repair method that we do is the forked flap. And for the cleft palate, the repair type is majorly von Lagenberg, and sometimes we also do the Badach approach. For all the repairs, all the surgeries are done at no cost to the patient. The only costs that they pay are those of them that require echocardiography, and we usually encourage them. And what we have done is to partner with one of our centers where I work, Federal Medical Center, Abeokuta, such that they are treated as inpatients. They are not treated as outpatients. The bill for outpatients usually differs from that for inpatients. So we have a partnership with them such that they pay a lower cost. Then that is the only cost that they pay. For the turnaround time, of course, when they come in, if we see patients in the neonatal period that's under 28 days old, we need to wait until they are 13 weeks, because anything short of 13 weeks, smile train will flag it. We have actually done it before. There was a patient that was 12 weeks. There was a patient that was 11 weeks, 5 days old, and the patient's weight was 6 kg. But because I was going to be out of the country for a fellowship program and I will not be around for a period, I took the patient. I was more concerned with the weight, which was 6 kg. So while I was away for the fellowship program, I got a memo from Smile Trade that we didn't follow the protocol, and I became agitated. I had to call Victoria that it was not true, that there was no case I did not following the protocol, because I approximated 11 weeks, 5 days to 12 weeks. So when she now gave me the name of the patient, I now apologize that I assumed because the baby was 11 weeks, 5 days, that I could approximate. So we don't do it. So our turnaround time is very small. Once they come, a baby that comes at 12 weeks, in the absence of any underlying medical condition, that week, the patient presents in a center, he will do the test. The following week, because we operate once weekly, if the test comes out, every parameter is okay, a week later we do the surgery. But of course, if the patient does not meet the Smile Train criteria for surgery, then we now wait till the criteria is met. Thank you.
Thank you very much, Dr. Ogunmuyiwa. Okay, another participant is a bit curious about the patient with congenital missing globes. He observed that the missing eye were always ipsilateral to the side of the cleft. And he wanted to know whether that was an observation that struck your concern, and if you have taken notice of such findings where the side of the cleft is usually where an organ abnormality is also found.
I observed
Do you
it,
understand
but I
me?
didn't. Yes, yes. Most times the missing globe is usually at the contralateral side of the cleft. But I didn't, I did not do further research to find out if that is what is, if that has also reported elsewhere. I just observed it. But now that I have said
Okay.
it, if I see subsequent ones, I will make effort so that I'll just do a case series report on it.
Okay.
Thank you.
All right. So, what do you consider the right protocol for adult cleft patients? For patients who present with untreated clefts at adulthood? What's your protocol, or what do you think should be right?
The protocol is similar to smile train protocol. For me, in my center, routinely, we don't do our repairs under local. Maybe because we have an anesthetist that is always available to us. So I would rather not want to struggle doing the repair under local. So for all adult cases, we do them under general anesthesia. I will give an instance of an adult case that was about 50 years old that we did. This patient had no underlying history of hypertensive heart disease. There was no history because she had presented to the clinic, because when they come like that, we take the blood pressure. There was nothing. Even when the anesthetist came to do his pre-op anesthesia review, anesthetic review, there was no history suggestive of hypertension. But shortly before we commenced anesthesia, this patient had marked elevation of the blood pressure. It was so high that we were looking through the case file, there was nothing. And the woman had to tell us that she's extremely fearful, that she believes that when she comes in for this surgery, that she may not come out of the surgery. So, of course, right there on the table, we counseled, and the anesthetist now, treated her, and from that period that we did the surgery till after the surgery, even the post-op period, there was no history. The hypertension the elevated blood pressure subsequently disappeared. So at that time, I was now wondering if I had attempted to do this case under local anesthesia, only God knows what would have happened. So I don't do any case under local anesthesia. If my anesthetist is not available, I cancel the case. We reschedule to when the...
Okay, thank you. I think Nicole. All right. Okay, I think Nicole wants to make a comment about that question also about protocol for adult patients. Nicole?
Sorry, sir. I didn't get you. Please come again.
Nicole?
Yes, I can hear you, sir.
Yeah, I think you want to make a comment about the protocol for adult patients, right?
No, I think what Dr. Stella said is totally right. We don't recommend local anesthesia for our patients. Even if they're adults, it's always under general anesthesia. So I totally agree with Dr. Stella. Thank you, sir.
Okay, thank you. Okay, thank you. All right. Okay, somebody wants to know about the patient who was about going for the youth service, who presented. Were you able to elicit from the patient some of the challenges, the psychosocial challenges he encountered going through school and growing up into adulthood with that kind of deformity?
Yes, we
Stella.
were. And one of the main challenges for this patient was the psychosocial issue that he had been having. But he said he had been to hospitals before, but he could not afford the treatment. And that was why he was really very particular that he wanted the treatment done before he proceeded for the National Youth Service. Because, during orientation camp, people from all over the country are usually camped together, that he didn't want that embarrassment again. So we saw the extreme psychological trauma that the patient had, and that was why we ensured that he had the repair done before he proceeded for the National Youth Service Corps.
Thank you very much. I was just wondering the kind of cost they must have called to him at those hospitals that made him really scared, because I'm not sure whether it'll be as much as the school fees he pays through school. Okay, fine, that's great. Somebody wants to know if you follow up your patient to adulthood, and if you did, have you been able to observe significant impact on the quality of life of some of these patients?
Unfortunately, majority of them usually in fact, it's very few that we see for 1 year follow-up. And that was why I said that that paper that we wrote to find out factors for non-appearance for scheduled clinic appointments is less than 20% of our patients present for 1 year follow-up period. So we've not been able to do that because they are usually lost to follow. In fact, there was a time that I was going through my archives to try, for those of them that have had cleft lip repair, I took time to go through the archives, trying to contact them with the telephone number that they put down with us. Majority of the telephone numbers had been reassigned. You know, with these people of the low socioeconomic class, once their SIM is lost, they rather go and obtain a new one rather than go through the trouble of retrieving that line back. So some of them, because they were quite a number, that immediately the cleft lip was repaired, they went away and never came back for the repair of the cleft palate. And this is also the reason why we are also not able to fully know the number of them that have come down even with fistula, because they will not come back. Most do not come back, though we try to follow up with telephone, but sometimes the numbers are no longer there. So we've not been able to do that.
Okay, that's a challenging one. That one thing I think we will look at in the future from your center and see how we can mitigate that kind of situation, because we all know that follow-up, the information from follow-up is very important to our practice and improvement focus. Okay, actually the person who had asked about the protocol for adult cleft patient wants to say that actually he wants to know about not just the surgical protocol, but the whole management protocol for that patient from point of presentation. Adult patient, the counseling, are there things you do differently for adult patients before the surgery itself? That's more interesting.
There is really nothing that we do differently for adult patients. It's just that for adult patients, their own treatment will come much more quickly because they will have all the smart train protocol will have been fulfilled in them, their age, the weight, everything, provided there's no underlying medical ailment. If I'm called that there is an adult case on a Monday, we operate most times on Fridays, an adult case on a Monday, and my medical officer has seen the patient, no history of hypertension, they've done the test, I can do the surgery within a week. Within that week, because for us, because it's a missionary hospital, we don't have issues of not having theater space or issue of strike. It does not ever affect us. So when adult cases present, if they present within a week, their surgery is done. So we counsel them. But there's an adult patient that I have seen. It's a case of isolated cleft palate. I've been sort of begging this woman. When she came, we observed that she had hypertensive heart disease. So we referred her to the physician. And just for her to procure medication, we actually could have, commenced our medication on small train bill. But we usually don't want to do that because it's not a one-off thing. Hypertension is not a thing that's okay, oh, for the sake of surgery, we know how we can crash the blood pressure, do the surgery, and she goes out. But we don't want to do that because it goes beyond that. And I've been begging this patient to come back so that to find even a way where we can, appeal to the hospital, maybe to subsidize her medications. She has refused to come. That she doesn't have money to even do that. So there's nothing you can do for them.
Okay. Okay, thank you very much, Dr. Stella. There's been a lot of commendations and accolades for you on the chat box.
Thank you.
Fantastic presentation, beautiful presentation. And that's right. Just before we go, and before I ask Nicole to pass a few information, let me also ask a few questions. I think you talked about your methods of repair, and unlikely make most of the times, and of course for leave relax and simplification most of the time. Now I want to know, are there situations where you think the patient could have benefited from maybe pre-surgical orthopedics, and what are your challenges with respect to that? Secondly, also for some large clefts where you have also shocks, velum and all of that, where you think problem of velopharyngeal insufficiency will be an issue. Are there things you do differently, especially when you talk about being unlucky most of the time? Are there things you do in such situations?
Okay. For those that may require pre-surgical orthodontics, for those that we think may require pre-surgical orthodontics, we refer them, we refer them to, because it is not currently available in our center. Some of these patients are referred to centers very close to us, because when I see them like that, I take the picture, discuss with my colleagues, and those were the ones that, I appreciated in the course of my presentation. I sent to them, and I send such patients to them to manage. But what was the other question that you asked, please? The second question.
Palopharyngeal insufficiency.
Yes, for some of those ones too, I send them out, but they are few. You understand? Because sometimes you discuss modification. They say, okay.
Yeah. Thank you. Okay. Finally, let's say this. What have you been doing your outcome assessment, both in terms of aesthetics and the functional assessment of your cases? Maybe aesthetic more for the lip, and then functional for the cleft palate. You do post-op assessment and then patient satisfaction survey.
We've done some patient satisfaction survey, and in some of the series that we did, majority of them are satisfied with the outcome of what they have. But some, though the patient may be satisfied, but from the surgeon's point of view, there are some of the cases that we are not satisfied with the outcome. So we are still work in progress.
All right. Thank you very much, Dr. Stella. It's been quite an illuminating time with you. And I think people have been really, really enlightened and informed about the kind of things you do there. Well done. So thank you very much. Dr. Nicole, please, you may want to give the audience some further information. Thank you.
Yes, sir. Before we close, I think there's remaining one question in French, and I'll translate in English for Dr. Stella. So the attendee is saying, thank you for the nice presentation. I'm very impressed by the publication, and I'm interested to know how they do it, if they are sponsored or not, and if the review is sold.
Okay, for the publications, they are not sponsored. When we write the publication, we look for papers, journals that will accept it, and we pay the publication fee. There is none that is sponsored. So they are not sponsored. So we pay the publication fee. Of course, there are some that you don't really need to pay, but for most that we have published, we pay a token to the publication. They are not sponsored. So maybe Smile Train in the nearest future can assist centers with a token for publications. But for now, Smile Train is not doing that. Those of us involved in the presentations, in the publications, actually pay a token where such is demanded. Thank you.
Thank you, Dr. Stella. Thank you so much for this presentation. And Professor Akadiri, we are so grateful for the moderation. And before we close, I really want to thank all the attendees for this participation. Since the beginning of this series, some of the attendees were very were always there attending our sessions, and we are really grateful. So this week we are ending the series 3 of Cleft online lectures in collaboration with WAX. And I would like to inform you that we will continue with the series 4 next week. So please remember to join us tomorrow for the last session. And as we said, this is a CME accredited program. So if you are interested in CME Point, I will send you, along with the recordings of this session, I will send the CPD form. And if you are interested, you will kindly be requested to fill it and send it back to me by an end of next week. And lastly, we will share with you a link to provide feedback about this series. We would really like to hear from you what you think interesting in this series and what will be your recommendations for the next series. Thank you so much. Compliments for this season. We wish you a very lovely week ahead. Bye-bye. Thank you.
Thank you.